Welcome, Dr. Hans. It's an honor and pleasure, as always, to have you with us. You're always a beacon of light and a guiding force to the ENT universe. Wisdom is what the ENT department needs right now from someone like you. So, again, Padmashree Dr. Hans, a very, very warm welcome to you.
Thank you very much. And I think I should be thanking you for giving me this beautiful device. The cordless endoscopic procedure thing. And frankly speaking, when I bought it, my idea was to have it just as an OPD instrument, to not only see myself but to show the patients what exactly. And when there is an autofocus thing, and even under great magnification, we can see the picture clearly. My aim was to just keep it as an OPD instrument. But later on, now I found, as we are doing more and more of adenoidectomies, we are doing FES surgeries, and not only that, endoscopic tympanoplasties, grommet insertions, and now if we get a good way of sterilizing the thing, I think I would also love to do stapes with this device, because it's a very light thing. You can hold it in one hand and see the picture right there in front of you. No wires, nothing of that sort. No dragging your hand and trying to bring it closer. The whole system connected to the wires. So I feel it is a wonderful device, and it is mandatory for every ENT surgeon to have it. It's a very, very important device, and I found it very good. OPD, yes, it was very helpful, but now in the operation theatre also, we are finding it very, very helpful.
Thank you so much, sir. Thank you so much. Mainly a question for the younger generation, sir. You're a legend in your own right and in every way possible, because we are very, very proud to be associated with you, and it's an honor to be. I just wanted to help some of the younger surgeons, when they have to make their first buying decisions. At times there are a lot of factors which come into play, and then there's a growing number of surgeons coming out of various colleges across the country. So everyone kind of focuses on OPDs and increasing their inpatient numbers in terms of surgeries, and they all focused on creating trust and value-based practices. So what advice do you have for the younger generations?
See, I must tell you that the confidence builds at the OPD level. Your patient will have a confidence in you once he sees how you are examining your patient in the OPD.
Wow.
And if you have the best of gadgets there, in which you can show and discuss them the problem they have, surgery is behind closed doors.
Yes.
Whatever you do actually is for your own convenience.
Yes.
In the OPD, you are actually having something, and the patients are also watching it and understanding what really you want to tell them.
Yes.
It's really very good. And if the confidence is built at that level, patient would definitely feel more confident going under your knife in the operation theatre. So I feel these products as OPD procedures are also very, very important. Even if you are not a ENT surgeon, even if you are an ENT physician, these things are very, very important. And nowadays I've seen many surgeons are happy being ENT physicians, and they're doing other things for their surgical part, like they're doing allergy tests, they're doing other things if they're not very confident with the surgery. So even if you're an ENT physician, for that matter, this is a wonderful device. You can not only show your intranasal examination, your otology examination, a beautiful laryngoscopy. You can show them your larynx, the vocal cord movements, everything is is seen so beautifully, that the patients feel very, very happy about it.
Oh, wow, sir. That is,
Yeah.
that's actually very
Very important.
well put,
Yeah.
sir.
Yeah.
And, because right now, sir, ENT is, like we say, every year is having a little bit of a metamorphosis.
Yes.
A skull base,
Yeah,
it's going
yeah.
into
Yeah.
so many dimensions.
Correct.
So, how do you see ENT in the future and when you started, sir?
Lot of changes. Lot of changes. Now it is from grommet insertion to cochlear implants to auditory brainstem implants to anterior fess to transsphenoid hypophysectomies. Then you have cancer surgeries, oncology. I remember we used to do just total laryngectomies and maxillectomies, and now people are doing very function-saving surgeries, and that's more important. So cordectomies and at a very good levels they have taken that.
Yes.
So you preserve the organ on which you are operating rather than just complete eradication of the organ as well as the disease.
Right.
Now they are trying to save the functioning of the organ by doing minimal surgeries. So that is possible only by the gadgets you have,
Right.
by the fine examination tools you have.
Correct.
So these things are very, very important now. And ENT has in the last 10 years gone from just being a tonsil, tympano
Yes.
surgeries to, something very, very
Yes,
big.
sir. In fact, there's some. If you draw a Venn diagram in skull base, a little bit of neurosurgery also
Yeah.
overlaps with ENT.
You can actually become an inner ear surgeon. I know of people who are just inner ear surgeons. That means they're doing cochlear implants and stapes, because stapes is footplate is a inner ear derivative. So they call themselves only inner ear surgeons. So that is the kind of super speciality we ENT surgeons have gone into. So
Wow, sir. And for a young surgeon starting up, sir, like you mentioned, everything starts in the OPD. So having good quality equipment with good imaging, helping them diagnose better, showing them what they diagnose and convincing them. In addition to this, sir, do you feel that younger surgeons, should they be like open up the jack of all trades, do multiple
No, I
surgeries
think-
and then move into something specialized? Or
I must tell you, I was a cancer surgeon when I left PGI Chandigarh. For 20 years, I kept doing head and neck cancer. Then I became a tracheal surgeon. Then I became a rhinoplasty surgeon. And then finally, I took up cochlear implants in the last 20 years, and I'm primarily an inner ear surgeon.
Right,
I do only cochlear implants and stapes. So, and I'm thriving. You can have so much of patience in just this limited field that you can sustain yourself very well. So I think, I used to remember when I would say that this surgeon only does knee surgeries. And I would say, come on, how can that be? But today I know that people are doing just knee surgeries. There is somebody doing only ankle surgery. There is somebody doing only elbow surgery. So we can be so super specialized that people start referring patients to you, and you do much better than those who are jack of all trades. So it is getting, as in the Western countries where people are localized to just one type of surgery, and they are getting patients because people are referring them from all over, the place. So I think you can start learning from the beginning rather than do everything and then shorten your, Yes, if you are going into otology, you have to do everything before you specialize in one
Specialize
thing.
in one.
Similarly, in neck, you have to do everything before you get into something. But as far as ENT is concerned, there may not be any need in future to do ear, nose and throat all by one person.
That's-
I think definitely we will have ear as super specialization, nose as super specialization, and throat as super
and I
specialization.
think that's absolutely
Yeah,
true, sir.
yeah.
The way it's going is,
Absolutely.
I think you've said
Yeah,
it.
yeah.
You said it very well.
Yeah.
And sir, in terms of because students come out of colleges and medical colleges, then they do some post-graduation programs and all. If they want to develop something specific, sir, for example, everyone aspires to be where you are. Like you're a mentor to so many, and you're an inspiration to so many. So the only time they probably get to see you is, it's like spotting the tiger. It's only during the safari, which is probably a conference like this where there's so many people. But if someone wants to learn from the mentor by observing how he conducts himself, because the surgery is only the end part, but way I know you start your day early and there's so much preparation for them to know how it's the environment you create. Do you think, sir, like training programs, short internship programs?
Yeah, we have it in our clinic, and if you come to my OPD, you will find it is a 5,500 square feet of OPD only, in which you have a CBCT, you have an audiologist doing the mapping and pre-op audiology tests like OE, BERA, and ASSR. Then you have speech therapist doing the AVT for cochlear implant. You have a psychologist who would also see the child, the IQ of the child and the psychological aspects of the family and the child. So you have under one roof everything.
Right.
We have rather an auditorium of 50 seats where we do these conferences. Where I can call 50 people and give lectures and all. I have a temporal bone dissection lab where people can actually come and do the temporal bone things. So they are welcome and they keep coming. I take them to surgeries, they assist me in cochlear implant surgeries and then come and do the temporal bone dissections. So we have a wholesome program, where definitely they can come and learn from A to Z of a program, whether it be cochlear implants or any other.
Right.
Vertigo is a big thing in our clinic. Allergies is a big thing in our clinic. So, if they want a particular thing to learn a particular thing, they can come and be with us for anything between 3 weeks to 3 months,
right,
and learn the thing.
That is something which is, it's great, sir, because they'll get a lot of in-depth.
No, and as seniors, we have to do that. We have to do that. It's our duty to do that.
Oh yes, so that's something very nice. I feel it's also responsibility to pass this kind of skill,
knowledge to
the next generation, so that
absolutely,
they can be less entropy, take it forward.
Correct.
We are into ENT solutions, and we have the entire plethora of products, and we really resonate with what you said. Everything starts in the OPD. It's the epicenter of your practice. So for making the right choices and investment on equipment early on can really set the direction for the in terms of practice.
No, I think we should have the latest equipments, because if we have the latest equipments, we feel confident, and the patients would also feel confidence. I remember we used to have the endoscope, but the wires would not work. You have to pull those viruses first. It will come out from that end or either from that end. This gives a very bad impression on the patient that the instruments are not working the way they should be working.
Right.
Now, this is a flawless instrument. Just pick it up. The image starts coming on the screen. You go inside, freeze that image, go to the other side, freeze that image, keep the instrument back and start discussing what you saw. So believe me, these kind of instruments would definitely help in creating a faith what the patient should have on the doctor. And these instruments are a step ahead in doing that, in helping the patient getting more confident on the surgeon.
Today, with so much of information out there, sometimes too much information is also it confuses patients, and it keeps them googling around and understanding things. But I hear, sir, that you take time with your patient, from what I understand. A lot of people are going for higher volumes and all. I do understand, observing your practice, that you take a lot of time with every patient. You show them each image, explain it to the patient and also their family members. So in terms of their stakeholders who are also participants in the decision, especially when it comes to little kids. So I would say that's purely clinical based patient education that you practice as well, which
See, this is really important because you must understand that the patient wants to understand. They should not Google and come to the doctor because then they'll get confused. You know, tinnitus can have 100 causes, and if they Google and come to the doctor, then they are in a very difficult situation, not only for themselves but also for the doctor. But once with the modern gadgets we have and modern systems we have, and also the doctor's view of what the diagnosis is after all the investigations, etc., have been done, and the doctor has come to a conclusion that this is the probable diagnosis, then they can go back and Google, and they should actually know. The doctor would also tell them, but they should also Google and find out what in the world is happening for that particular thing,
Right.
the treatment modality.
Right.
So I think to Google and come to a doctor on the symptomatology of the disease is very, very dangerous.
yes,
But once you form a diagnosis, and that is by the instruments the doctor has and the knowledge the doctor has and the experience the doctor has, and then once the diagnosis is made, you go back to the Google and see what this diagnosis is and read about it and learn about it. That is much more helpful, and I always tell my patients
Oh, wow.
to do that. You know, once the diagnosis has been made, now you go back to your Google, find out more about it, what your doctor has told is good, or there are any differences somewhere. That is very, very helpful because then he gets the confidence, yes, that this is the symptomatology, this is how the doctor explained, and this is what I feel also now that inside my body this is happening. Then the Google becomes very, very helpful. Otherwise, before coming to the doctor, Google is a disaster. It is bad for the patient, it is bad for the doctor.
The
I'm very
information
fair as far as all these knowledges are concerned. The knowledge, the IT knowledge, the Google knowledge, the internet knowledge, these are very valid things. This is what people tell and how we learn. But they should not do before they are diagnosed.
right.
Because on symptomatology, if you start diagnosing yourself through the Google, that it becomes very, very dangerous and sometimes irreparable.
Right,
You know,
right.
the patient has got fixed onto something and then he doesn't get out. It becomes very, very difficult. But if the doctor, senior doctor, he has seen it, he is examined, got the investigations done, and is sure that this is a diagnosis, and he says, yes, this is probably 90% or 100% the diagnosis, then please go and Google and find out
Right.
what it is all about. Then Google is very important.
A little bit about, you're very humble by, I try to request you to start from the your achievement, but you said, that's a part of life. But
I know.
there's a reason why there are very few individuals who've been facilitated
No,
by
I think
the
I think
president.
everybody has the knowledge. They have come through a process. Everybody has the knowledge, but if you apply it properly, then you are a success. I always say, and that great people don't do different things. They do things differently.
Oh, wow. Very true.
So
Very
if and I can give you my example that I saw people doing the cochlear implant through the posterior tympanotomy, but I think this is not the right thing, particularly in children. And applied my mind. I saw my mentor from Greece, Dr. Trifon Karadzici, doing the transcanal, and I immediately understood just because I had read about it.
Right.
And then when I went back, I read more once I saw him. I was convinced that this is the technique. So I did it differently and proved that this is a beautiful technique, and it has now 25 years and the results are very beautiful.
Wow. I think that award is very well deserved,
Yeah,
and it will be that inspiration for everyone.
Correct.
Like you said, it should be a part of your practice.
Absolutely.
I think you, from what I realized, it was like a surprise. It was one phone call suddenly saying, we love the direction in which your practice is heading, and we'd like to see. But sir, like I can understand why there's a 1% who actually think like you.
Correct.
It's because you think and practice with your heart, from the way I see it. And
No, I think
there's a greater good involved.
I think to imbibe new techniques and technologies is the need of the hour. You have to. because science is dynamic. It will keep coming up with better things. And if we fall back on the same techniques and technologies what we were doing about 20, 30 years back, we will fail, because science is completely dynamic. It keeps changing. You have to be in touch and keep changing and imbibing technique and technology both if you really want to remain successful in life.
Wow. Thank you so much, Dr.
Pleasure.
Hans.
Pleasure.
It's an
Thank you
honor
very
and
much.
pleasure, sir.
Thank you very
Always.
much.
Thank you.
Thank you.